make you put that seat well so that she go put move am away until when she enter, go forward before you go bring the seat to the center now. Make she they go forward more. Good. Where the lapel mic now? Why on no put them? Yes, my sister. Good morning.
Good morning, sir.
You go tell us your name.
My name is Mrs. Charles Joy Wog.
Mrs. Charles Joy Wog. I don't know whether 5 minutes go there too small for you to take summarize the matter where carry you come so that we go call the doctor straight away. Okay. Is they too small?
No, they too small.
You go feel summarize them under 5 minutes?
Yes.
Oh yeah, summarize.
The matter where carry me come now, my eye. I've been the work for Bayelsa, so they bring a national NHIS, say make all the workers them where they go take treatment where they like. So I choose a teaching hospital Bayelsa. The doctor tell me say I get glaucoma, so he begin give me eye drop to use. At the time he tell me say glaucoma the eye drop is not helping you, so you go for surgery. He can direct me go FMC to go meet one doctor, Oko Omaka, for the eye surgery. And he say, now try beg them to do for me. So I can't go meet the doctor. Reaching, he say, NHIS is owing them. So I should go and pay. After I will write letter for refund. I can't tell and say, me, I'm a student too. I have my dissertation to defend. He said, no, well, I say, how long will this surgery last for me to be healed? He said, no problem. For 1 week, the thing will heal. I say, sugar self, they say it dey for body. And my doctor, where they see me for the teaching hospital, say, make I not do anything surgery because the healing process will be low. He say, no. Say, no, wahala. He know what he will do. Make I go pay. So I come pay. Carry me enter theater on the 10th of August. They do the right eye. The following week, he say, make I come for follow-up. I come for follow-up. I no fit see road with the eye again. He say, hey, the pressure is too low, it's 2. So I cannot see with that kind of low pressure. So he go carry me enter theater again, make him go deep in the AC. And so he tell me, carry me go again. Tell me, say, after 1 week, make I come, make him see him. As I come the other week, they ask me to go and read. I go read that thing where they read. I read them well. He come talk, say, he won't do the second one. I say, no, do the second one. This one never heal. He said, who tell me say this one need to heal? I said, I beg, make this one heal well before you enter the second one. He said, look, this left eye way there now. Say remain 5% now, he will die. So he's taking the best decision for me. I said, okay, I'm not doing because I didn't inform my people, say I can't do anything. But the day when we do this surgery, when you do for me, a lecturer working in Federal Polytechnic, Ekewe, Bayelsa State, Mr. Chika Lemadim, he did the same surgery when he do for me. So that man can't come out because 2 of us enter the center. When they tell me, say the doctor is explaining how he meant well for me. So sister say he would have advised me to call my people. She will come and carry me after the surgery. So I should go and pay. I don't know. He encouraged me. I went and paid. Enter the theater. He do the left eye. After he finished, he said I should go to female ward. As I reach female ward, Contour say, he can't check me. Say he forget something for my eye. I shout. Say, what did you forget? He said, make I no worry. Say there is a place in open, in cut open, but he no suture. So make I go. The following day, I said, doctor beg, make we go back immediately. He said, no problem, make I go. Tomorrow, make I come back. I can't go. Tomorrow, being August 25th, because in do I'm on the August 24th. On the 25th, being Wednesday, I go back. Carry me enter theater again. As soon they saw the thing, the suturing rope they cut. In the side, say, oh, this suturing rope is cut. Me, I can't complain. Say the thing too tight, oh. He say, I beg, you know what thing they do. As soon suture finish, pain start. Say right eye drop. Say make I go. Come the next week. I go. Come the next week. I say the pain dey too much. He say make I go buy medicine. He write medicine. I go buy injection. Say him go carry me enter theater again. Make him go check the sutures. Then check. Give me injection for eye. And carry me enter the third one. Give me the injection. Finish. Waiting him do finish. He come tell me say make I go. Come back again. I say but this eye no can't take and the see road. He say make I come back. When I come back, then go check. When I come back again, I say I no take and see road though. The pain was too much. I can't call that man wey him do the same thing. Say na this same pain wey I dey get you get. He say na the same pain o. Say no fit endure. So he don call the doctor. He don come comot wetin him do for him eye. I say give me the number. I call am. He say no, fit come back to Bayelsa until the week. He dey come every Tuesday. So Tuesday I come go. When he see me, he surprise. He shout, say Jesus Christ, the eye is overinflamed. Cataract has come out. I say, but I no get cataract. Now how manage? He said that is the complication of the surgery. He said, oh my God, lose this eye now. What do we do? Everything in FMC has broken down. Even the time that he's taking me back, that is just managing the microscope and the thing. I say, doctor, this thing no be something of managing. This thing na eye. I was seeing with my two eyes when I waka enter here, and now I can't see with the left eye. So he come talk say, what do? You have to come to my private clinic in Port Harcourt. Make I see whether I go comot the cataract for you. I say I don't hear. I can't go back to Port Harcourt, tell my husband. My husband say, call your brother, oh, this thing na eye, oh. Make una find way where una go take do. And this doctor wey dey enter your eye, come out, enter, come out. Now he still carry this eye go give. I no dey. So come call my brother. My brother say, well, make them find where they go carry me go. At least make them check how they go take correct if there is anything that is wrong. They can't carry me go Telish Hospital, Kaduna. They say Indians they work there. I go there. They say make I go do scan first. After the scan, an Indian doctor see me, say it's not a glaucoma specialist. The eye is gone. That is not, we can't use it for vision any longer. That is, but the shunt in the eye should be removed. I said, okay. I was ready to remove. They said their glaucoma specialist is not around. So I told my brother, he contacted one of our sisters working in National Eye Clinic. He said, make I come. I go there. The glaucoma specialist saw me and said, what did they do to you? I said, Tribex. He said, this cannot be Tribex. Said, nothing will make her touch this eye. She examined and said, whatever that they have done, they did not do it correctly. Say, now the left eye is gone, but the right eye is what I'm talking about. If anything is not done quickly to correct it, you will go blind very soon. So I said, ma, please do something. He said, there is nothing he can do. He will allow another doctor to see it. So they call one Yoruba doctor.
Your 5 minutes is almost exhausted. So I am saying this so that you can focus on the most important part.
Important thing. So now, so I go back to him, come back from Kaduna, come to him. He refused to do anything. So after all said and done, I said, okay, since he refused to do something, let me go back to where the insurance company said I should be taking care since they have not settled with FMC. And I went there. So the man keeps referring me to various hospitals until I come down with low vision. I went for low vision assessment in Calabar, where they referred me. They said no more vision again, that I should go for rehabilitation. That is how I see myself blind now.
Thank you very much. And you remember, say, this na the third time when we air this matter. The first time na Saturday. And that Saturday, we've been called Dr. Oko Omaka, and he tell us, say, that day, he no remember you. We try, you narrate the story back to Ram by yourself. You took more than 15-20 minutes to narrate the story to Ram until towards the end of the program, he come talk say, waiting you the narrate, don't they come to light at all, small. Before that time, he been talk say, why when we they wonder how he no fit remember you after everything where you don't narrate. We they ask him whether in they forget something easily, he gets anything like that. He say no. He come begin say our patients where they see no be small, say the number plenty. We can't ask him say, okay, with all the things where you don't narrate, does it mean that the patients where you don't they see will get similar experience, similar problem? So tell you narrate, talk how you fainted in his office. You narrate, talk how when you go meet him after the 5 surgeries will happen within the space of 22 or 21 days, not be 1 month. 5 surgeries will happen within a space of 22 days. You confuse, say, Kai, it be like, say, this thing don't they turn to be careful. You go Kaduna, you go see one Telish hospital, am I correct?
Yes, sir.
And then from there again, they look you. The doctors look you, say, who do this kind thing for your eye? Waiting this person do, we no go touch him, so that they no go carry waiting we no do, come put on our head, go back, make the person where do this thing, make it correct am, make it remove am. Now be the problem where you dey get. You no stop at that one hospital according to you. You can't enter National Eye Center for Kaduna again. You meet another doctor as you talk. The same doctor look you again. He say, Kai, this thing where they do for your eye, who do am? He begin ask you like say, no be eye doctor na carpenter or tailor, come sew something put for your eye. Say, who do you this kind thing? And you begin beg him and people they beg, say, help me. He say, no, I no go touch him. And according to you, the reason why they talk say they no go talk be say, they talk say, waiting they do to you, know they professional. And them themselves, no one put their hand inside. Make it no become when complication day. They go come talk say, na them or they join, make the complication worse. Say, make you first go back to who do the thing, make you remove them. All of this we explain to Dr. Oko on that Saturday. In talk say, before we close, say, it don't they come to life small. But because this program, we know the judge matter for one person mouth. We want make we give the same fair treatment to you as we give to Ram. We give to Ram as we give to you. The same fair hearing and equal opportunity. Now we come tell and say, make it no be like say we they just force them or they ambush them. Make we allow them time. Make it go look in folder, look in the hospital, discover who you be. He can't ask your name. We give him your name. We agree saying on Monday we go call him. We call him Monday. He can't agree say ain't don't know you from that Monday. Come begin narrating on things. As he they narrate, I can't raise some questions. Even other people ask. One of the questions where I raised that Monday be say, how he be say in a space of less than 1 month, about 22 days, he carry you enter theater for surgery for 5 times for eye on the both sides of the eye. He can't say no, say nothing like that. It no happen. As we begin to question him, he talk 2 things. He talk say he carry you enter theater no mean say that for surgery. If it enter theater for not for different thing, then he can't talk another thing. Say he know the issue. We can't ask him say how come you know the issue. He say he never see your file. We say this one another side of the story again. Since that Saturday till Monday for matter like this, you never see file. Make we no force you to answer what you know. No, go back again. Look your file. We agree. Say Ingo go look the file. Say today will be Wednesday. We go call him back. He go tell us waiting in file for your file. Now I go call him. Make we hear from him. As if he say you don't talk your own side.
Hello, good morning.
Good morning, doctor. How are you?
I'm good.
Okay. Consultant Ike is my name again. And me and you there live on Brekete Family. Human Rights Radio and Television. Are you following us live?
No.
Okay. But the reason why I call you, at least you know, now concerning our sister case, Mrs. Joy, Charles.
Yeah, I know.
Have you now been able to access? Have you now been able to access her folder?
Yes, and it's quite revealing.
Oh, beautiful.
It's quite revealing. Yeah. So I want to just firstly sympathize with Mrs. Joy concerning her situation. I wish it didn't have to turn out this way, but I think many odds were interplayed on her case. I want to also make it very clear that she needs to make a commitment that her medical records will be put on public display because of patient-doctor confidentiality. Normally, we are not supposed to disclose what we get from our patients. Whatever we discuss with our patients is supposed to be between us and the patient. In fact, it's so bad that you are not even supposed to tell maybe for a couple, you're not supposed to tell the spouse of that couple what you elicited from, unless the couple gives you, no, unless one partner gives you the go ahead, to do that.
Okay. Now this we will let her answer. She will answer. She will answer you.
Yes, I want her to make that.
Okay.
So that whatever.
Give me the other microphone.
Sure.
She will answer you. I'm going to her now to let her answer you. And then before I get to her, I want to ask you one quick question. This medical record of hers where you get, is she entitled to a copy of it?
I'm not sure how. I think she should be, in the sense of getting a medical report.
No, if it's her record. No, if it's her record, she is entitled to it.
That's what I'm saying. That normally patients don't handle their folders.
No, it's not about giving her folder. I say copy. I keep the folder, but copy.
Folder is about the contents of what is in it. It's not about just a file. It's about the content. So I'm just saying that she can get. I know she's really entitled to is a full medical report. So that can be used anywhere in the world to judge her situation.
Okay.
And I also want to state clearly that the first time I was called, so many things were hazy with me concerning this patient, because this happened 2021 and this is 2024. I see an average of 50 patients a day, and there's no way you expect any doctor in the world to keep up that length of time to remember vividly what he or she underwent with his patient or her patient.
That was why we forgave you that first day.
Thank you, I appreciate that. And then the area of specialty that you were talking about.
Hold on, let's take it bit by bit.
No, I know. I want to clarify all these things.
Can you hold on, sir? Now me call you. No be you call me. So let's take it bit by bit. First, with respect to her records, she is entitled to whatever record anybody holds for her or against her, as far as it concerns her anywhere. International privacy law, document law, private data law, all of that. She is entitled to that if she asks for it. But let me allow her answer you what she asked. Yes.
So you don't need to force this. I'm telling you what I know. I am putting it to you that this is what I am familiar with. So if you want to seek address in any other way, you are free to do that.
Okay. Have you finished putting it so that she can answer you?
Okay, please.
Have you finished?
Yes, let her answer.
Okay, remove it now. Madam, did you hear what he asked you?
Yes.
Whether you are permitting that he should put on public, discuss your medical condition according to the record he has.
Okay, let him discuss it.
Open mouth and tell.
Let him discuss the medical record.
Doctor.
Yes, sir.
Did you hear her?
Perfectly.
Okay. So now go ahead.
I'm on local standing.
So now
you mentioned.
Hold on.
Okay.
To enable us have this as a dialogue or an interaction, you will take a component of the things you want to respond to. You give your response, then you allow us to give you feedback on them. Or do you want to run everything all through before we give you feedback?
I think I prefer to run everything through.
Okay, go ahead.
And then I can now take questions.
Okay, go ahead.
All right, thank you very much. On the area of specialty, glaucoma, retina, and all that, and as an ophthalmologist, is trained in all these areas. And then If you want to seek special interest in some certain areas, you are free to do that. If you can get specialist training in any particular area, you are free to do that. So that's aside for the area of specialty. I want to just say that I would have to do a lot of education, because this is me talking to laymen as far as our medical terms and terminology is concerned. So you permit me, I'm going to talk a bit about what glaucoma is all about.
Yeah, but keep it focused within the context of this discussion. Focus it on the patient matter we are discussing.
Yes. It's so that when I'm talking, they are saying things from a doctor's perspective, because one thing I do with my patients, I try to make them understand what actually is going on, so that for me it makes it easier to manage them when they understand or get a full grasp of their condition. It's easier to manage them. My dad is dead as of this year, and he was completely blind for 18 years before he died. And he died because of glaucoma. I'm sorry, he got blind because of glaucoma. And a lot of people have asked me, is that why I entered the eye and all that? Well, I didn't specifically enter the eye area because of my dad. It just happened. By the time I started my residency training, he came in and we found out that one eye was gone, and he had like 5% of his nerves left. And at that point, I knew that it's not going to be too long for him not to see again. Of course, he was given drugs. His pressures in the eye were very high. We tried to bring it down then, but I still knew that the 5%, considering his age and all that, would eventually go. And so it happened. To keep him alive, I kept giving him encouragement that doctors are working to see how this stench of glaucoma will be eradicated. Because of my dad, I started an eye foundation to help people who are indigent.
I thought we agreed to focus on the conversation directly relating to this woman matter.
Consultant Ike, don't worry.
No, it's not about worrying. It's about timing.
Okay, fine. Now, glaucoma is a leading cause of irreversible blindness, and it has to do with your pressures in the eye being too high or even too low. And yet there's evidence of nerve damage of your eye. It's the nerve that transmits eye signals from your eyeball to your nerves. All right? And everybody is supposed to have about 70% of their nerves intact, at least more than 70% of their nerves intact, to be able to have useful and normal vision. All right? So let's bear that in mind. Mrs. Joy Charles opened folder in FMC about 21 years ago. I think she was about 32 years then, for other medical conditions. But she was diagnosed in 2007 for pulmonary tuberculosis, which they said which was found to be secondary to some form of compromise.
Dr. Oko.
And her first presentation. Excuse me.
Dr. Oko.
Yes,
Dr.
sir.
Oko, we are talking about her complaint about the surgeries you carried on her with respect to glaucoma. Why are you not focusing on it?
That's what I'm going to.
You
I know
don't
why I'm
need what you are doing. Why are you not focusing on it?
Okay. Her first presentation in the eye clinic was on the 6th of August 2012 in FMC. Her visions were normal. She came because of redness and a diagnosis of chemical conjunctivitis was made. She came some other time in 2014. She also came 2015. And when she came in 2015, at one of her visits, it was found that she had tension. Her pressures in the eye were very high. Okay, all this happened even prior to when she was now referred to me in 2021. She was also found at that point to have cataracts in both eyes. Her pressures were 25 and 28. You must know that the normal pressure for the eye is 10 to 20. And that was why we made the diagnosis then. I even made that diagnosis of ocular hypertension in her eye. And she was given glasses and given anti-glaucoma drugs. I was instructed to keep up a follow-up because of a possibility of nerve damage considering the high pressure in her eye. She presented again on the 22nd of May 2018. Again, having defaulted after we talked about her having ocular hypertension. She came this time again, and her pressures were even higher than the first one. And of course, at this point, she had started developing nerve damage. She was cautioned and given anti-glaucoma eye drops again. She came again 3 months after. Pressures were still high. And she was cautiously, told that, please, madam, this is glaucoma. Try and keep up with your, because you don't have the paraphernalia or the parameters to be able to check your pressure at home. Glaucoma, when your pressures are high, it doesn't give any sign. For some people, you might have headache, but it's not for people to have headache, so you cannot even attribute it to glaucoma. So try and keep up with your follow-up. So let's monitor this thing and be sure that it is coming down and there's no nerve damage. It was at that time that we also asked her to do a central visual field. Central visual field is done to show how damaged your vision is from glaucoma. When she came with the result, it was obvious that she had started developing marked visual changes, particularly on her left eye. All right? And then the last time she came to us, before she was referred back to us, was on the 17th of March, 2020, 2 years after. We were very upset with her. How would you have gone away for 2 good years? And the diagnosis of poorly controlled advanced glaucoma was made. She complained actually what brought her was the redness in the left eye. And her pressures now were even much higher than what we were getting previously. 30 on the right, 32 on the left. And her nerve, what her nerve was left on the right then was about 5%, about 50%, and about 20% on the left eye. She was consequently advised to have glaucoma surgery, precisely trabeculectomy. I think that's about the first time she would have heard that term, which she has always been calling trabeculectomy. We didn't see her again until 1 year after, when she was referred back to FMC from NDUTH. She was my senior colleague and professor of ophthalmology, actually called me on her case, and I didn't know that she's even a patient that we had been seeing before. He called me and was telling me that they have been trying everything possible to bring down her pressure, and it was not responding. Pressures kept being high. They even had put her on drip. There's what we call mannitol. Mannitol 20%. She used it to bring down pressures both in the brain and in the eye. And that he had tried all of that and the pressures were not coming down. As of the time she came to us, her pressures, that's on referral, her pressures were 32 on the right and 30 on the left. Remember I told you that normal pressure is 10 to 20. So you can see how far apart her pressures were. This time, her nerves had greatly reduced. On the right eye, she had 15% left of her nerve, and on the left, she had 5% of her nerve, just the same way that presented. At this point, a diagnosis of end-stage glaucoma was made, and there was very obvious what we call tunnel vision. She already now had tunnel vision on the left. Tunnel vision is like when you are looking through a pipe. You can't see things around you. You just center. And such people, if it's in both eyes, are liable to be seen bumping into objects, by their side, because they can't see their periphery very well. So you see them, when they are coming to you, even in the clinic, their shoulder will bump the edge of the door. Immediately, as a good doctor, you would know immediately that this is most likely an end-stage glaucomatous patient. Her visions were, however, relatively good. Worse, though, on the left eye. There are parameters for which we use in checking objectively how your visions are. How well do you see? There are parameters we use in checking that. So on the right eye, it was relatively okay. And in the left eye, it was, let me just say, borderline. This, of course, reflected in the extent of damage on her nerve. Remember I said she had 15% on the right and she had 5% on the left. So it's understandably why her vision on the left eye was more depreciated than the right. At that point, the nerves are very friable, and I talked with her that instead of doing the trabeculectomy, which is an invasive procedure, that I would prefer to do glaucoma tube surgery. That one is minimally invasive. It's just about connecting a tube by way of a shunt into the eye where fluid can drain. The whole essence of glaucoma management is to reduce the pressure so that further damage to the nerve would be halted. So I didn't want a situation where I'll be, using the invasive type, and then she loses her vision maybe just immediately after, and she will now say that it was why I was doing the surgery that she lost her vision. It has happened a number of times, and that particular syndrome is called a wipeout syndrome. The complications of glaucoma surgery, in addition to cataract. Remember that she already had cataract before now. Of course, if you do any surgery on her eye, the cataract will definitely worsen. And cataract development is one of the complications that come with glaucoma surgery. So consequently, surgeries were done for her. The right eye was done on the 10th of August 2021. This was like after 2 or 5 months after she was referred. And then about 14 days after we did the right one, we did the left one. So on the 17th, so let me just narrate what happened in between the surgery periods. On the 17th of August, which was 1 week after we did the surgery on the right eye, her pressures came down to 6. From 35 thereabout, it came down to 6. Of course, we have not done the left eye because the pressures is understandably why the pressures were 42. But by the time we finished, the pressure being 6 was very low, and that alone is another complication because you don't want very low pressures, So I had to take her back to the theater. That's when because she mentioned something about deepening AC. That was the reason for deepening the AC to, make the pressures come up a bit so that she doesn't have any issues from very low pressures, which we call hypotony. And then the same thing when her vision was now good, back to what it was when she presented, we decided to do the second surgery for the left eye. I chose the right eye because she had more potentials on the right eye. And if the right eye is successful, then we can do the left eye for all it's worth. And believe, that if, you halt further damage on the left eye with just 5%, maybe she would be able to pull through the 5% for as long as it takes. And then we did the surgery on the 24th of August. On 31st of August 2021, 1 week after the surgery, of course, the vision on the right eye was still very good. The left eye, the vision was not too good. First day post-op, the pressures were now very low. It was about 4. So I had to do the same thing I did in the first one and got it up to 12 by deepening the AC again. So I think this should be about the 4th time or so that she went to the theater. By and by, the pressures were stabilized at 18 on the right and 12 on the left. And her vision then was very fine on the right eye, and on the left eye it had come to 624, which is relatively okay considering the extent of the nerve that was damaged in that left eye. She presented again in September, and this time she was having the vision had gone down, and she talked about having pain. And by the time we examined, the pressures that were 12 had gotten to 40. And when we saw what was happening, we made a diagnosis of overwhelming uveitis, which was secondary to poor post-operative drug compliance. I can remember vividly this one where she said the drug she couldn't find it to buy, and she wasn't taking it. So that's when I quickly, uveitis is inflammation of the eye, and we needed to make sure we curtail that inflammation. This necessitated me to take her again to theater to give her steroids. Steroids are anti-inflammatory injection, which I injected inside her eye so as to contain she had. She eventually got better. The pressures were curtailed, and her vision, of course, did not improve because the cataract had gotten really, really mature, and the pressures were now better. And I told her that it is good, that we bring the pressure down, because once your nerve goes, you can't see again, no matter what is done. There's nowhere in the world you go and see, because nerves don't regenerate. Once they are gone for good. It's like having your fingers chopped off and you're expecting them to grow again. But that cataract is like a veil disturbing your vision. It's simple, just remove the cataract and then you would be able to see, as long as your nerve and the back of your eye is healthy enough to serve its purpose. So I urge her that it would be nice to take out the cataract. The next thing, of course, I didn't see her again until after a long while, some months. She came and, was talking about that she has gone to other places, that she met her brother. Her brother said that I've taken her to theater several times, that he's going to send her to somewhere else, that if at all she has to go to theater again, it's better she goes somewhere where it will be done once and for all. And that she had gone to Abuja She had gone to Kaduna. She mentioned quite a number of places, and that they said they can't touch the eye because of the tube, that she thought I did Trabec. She's telling them that I did Trabec, that it's not Trabec I did, that there's a shunt, there's a tube there, that I should remove the tube. They cannot touch the eye, or else they cannot remove the cataract, remove the tube. So at that point, I was like, why didn't you come all this way? He said, no, that is the brother that insisted that. I said, okay, fine. She said, in fact, if I can, I should remove all the tube because they are saying they don't understand the tube. I told her that it's quite understandable because tubes come in different forms. I have had to see patients with tubes, and I normally would always tell them to go back to the person who put the tube, who knows the extent. Unless there is something to show precisely what tube that is in the eye, you don't want to start feeling in search of the extent of the tube. It's not like she mentioned something about being a health worker that puts and remove implant. And of course, that implant for contraception is one kind of implant, that you implant under the skin of patients and all that. So, of course, that's why it was it's within our jurisdiction to remove, because it's not that difficult to do. But of course, for the eye, you can't play around the eye when it comes to removing implants in the eye. Unless you are very sure what the implant is, that is when you can go. But when you're not sure it's advisable, you don't even bother. And of course, they must have seen the other eye, and they're saying that she's already an end-stage glaucomatous patient. Most of my colleagues would not want to operate on an eye that is end-stage because you having just 5% of nerve remaining. In the process of doing the surgery, you might lose it, and then you begin to blame them. So most times we try to keep clear, from areas that would bring us into this issue now that we are discussing, and all that. So I told her, okay, if you so insist. She was not saying that they want to do laser. They want to do laser. They want to do laser. That they want to use laser to remove the cataract. And that's why they want to have the tube removed. I said, fine. And I did that pro bono for her in my clinic. Okay, it's not a big deal. I removed the tube. I removed the tube for her. And that's all. And that was the last time I saw her. Only to be called up now to say that she's accusing me of destroying her eye. And I find that, really, really embarrassing because I know all the times I even took her to the theater to dip in the AC, to give her injection in the eye. I used to beg the matrons that please, let's assist her. Her condition is pathetic. Let's assist her and all that. And they used to collect money from her on those repeated times as she's supposed to pay. She was not paying, and to find out that such person that, I was, drawn to within the situation. For me, anybody I see that has glaucoma, I'm usually a bit more proactive because my dad was blind from glaucoma. I'm very passionate about glaucoma patients. And that's one of the leading reasons why, I had to set up a foundation, in connivance with my partner. So it's really, really disheartening for me to have her come online to accuse me of ruining her vision, which I did everything in my possible best to preserve. So I really sympathize with her, what she's going through. I truly understand what she's going through, and all of that. And just to add here that even her medical conditions, diabetes and all that, will definitely worsen the prognosis of her glaucomatous condition. You can read it in journals. It is a synergy. It's the same thing as hypertension and diabetes. If you have hypertension and diabetes is helping the hypertension to cause more havoc, and the hypertension is helping the diabetes to cause more havoc, that the two become, brother and sister trying to ensure that the life of the patient is a living hell. So I think that's what's really transpired in her case, and I truly, truly sympathize with her. Thank you very much.
Thank you, Doctor. Dr. Oko.
Yes, sir.
Thank you very much for taking your time to explain your own side of the matter. Thank you.
So I can take questions now, if there are any questions, please.
Okay. First is, I am appreciating you, and I thought you would have acknowledged that.
Thank you very much, sir. Thank you, sir.
Thank you. Are you happy that you had the opportunity to explain your own side? I didn't interrupt you, if you remember.
No, I'm very, very happy.
Thank you.
Thank you, sir.
Now you have spoken. We ask you questions, or that's we ask. But I will want to start from the patient, because it's possible that there are certain things you have explained that is not exactly the way it is with her understanding, just the same way that some things she explained were not clear to you. I will want to first give an opportunity to ask you questions or to remind you. Madam, is not an argument point, but you listen to him. If there are things you will want to ask him, maybe to remind him if there are things he explained that were not exactly the way he explained it, maybe that could remind him. You understand? And you know also, he's not God. He won't remember everything. That's why it's like he's reading from his notes. He has to go to his folder. So can you ask him any question if you have?
Yes, I have a question for him. The first question I have.
Are you hearing him?
The first question.
Are you hearing her, doctor?
Yeah, if she can be louder, better.
The first question I have is this. You said that I came with end-stage glaucoma. End-stage glaucoma that I came with. I was able to read the snare chart with my 2 eyes. There was no problem before this operation is being carried out. That is the first question I'm asking you. Then I want to still ask you again. Did I mention the doctor seeing me at ND2H, and did I tell you that he said I should not go into any elective process? Dr. Bozimo, he works in FMC, he works in ND2H. Did I say so?
I can't remember that.
That's the second question I told you. Now,
let's take it one by one. Has he answered
the first one? I said, because he was saying that I came with end-stage glaucoma. So somebody that came to the hospital for end-stage glaucoma, that means the professor who referred me did not saw it that it is end-stage glaucoma. Because if the glaucoma has come to an end stage, I don't think that surgery is required again to do in that person's eye.
Okay, let me help. Doctor, what she's simply saying is that if she came with
I understand what she's saying.
Okay, no, it's not only you that is in this conversation. The same way you spoke to us as non-technical people in ophthalmology, we try to amplify some things for people that don't understand to understand. Even this question she asked now, I have also one that is very close to it, so that we don't repeat ourselves. You talked about the percentage of her nerves when she came. What was the percentage of her nerves when she came? You mentioned that the last before the surgery.
Yes.
The very last.
Yes. I mentioned that. I said the percentage on the right eye was 15%.
Mm-hmm.
That means she has lost 85%. Mm-hmm. And then on the left, what she had was 5% left.
Mm-hmm.
That means she has lost 95%.
Okay. Now, we are joining it with this her question of, if her nerves were at that level deteriorated, and then she came with end-stage glaucoma, as you talk, why then did you still see surgery necessary at that point?
Fine.
Madam, I hope that's the question.
No, she also mentioned that she was able to read the chart.
She mentioned that.
End stage. Yes, if it's end
no,
stage.
but if you answer this last question, you will answer the other one.
I'll answer the two. So you see, glaucoma does not damage your senses. There are two sides of vision. We have the peripheral vision and we have the central vision. Okay, glaucoma destroys your peripheral vision first. Peripheral vision is what you use mostly, like when you are driving. You know, you need to know the circumference of, see the side of your car so that it doesn't bump into the other car. That's peripheral vision. All right? You can even examine it yourself. If you put your finger by the side corner of your eye and you're looking straight and you observe it, you can still see that finger. That's peripheral vision. Central vision is the one that is just in front of the eye. And that is the best kind of vision. So, of course, and that vision is about the last that glaucoma takes away.
Okay, that was what she used to read the snare chart.
So it was, yes, that's what she used in reading the snare chart.
Thank you. Well, thank you, doctor. So the last question now.
Why I felt surgery was necessary was because her pressures were still high, very high. And at that point, what will you do is like you just watch her go blind faster than necessary, faster than she should. I mean, within a space of 1 year, she had gone from about 40%, 50% left to 15% left on the right eye. And on the left eye, she had gone from 80% left to 5% left within a space of 1 year.
So was the surgery?
Drugs were not working. They are giving infusion, it wasn't working. And that was the reason, this particular reason why the professor sent her back to us. They didn't have the expertise or the facility to do that. We did in FMC. So, I mean, I can't just watch her. So it was just, I did everything to convince her, and that's why she accepted to do the surgery.
So was that surgery? Okay, doctor. Was that surgery meant to recover her vision or what?
No, the surgery was meant to preserve what is left.
What was it that was left?
The 5% of the nerve that was left.
Not her vision.
At that point, her vision was like halfway on the left.
What of the central vision that was left?
Yes, it was fine. It was fine. That's why she said she read.
That's what I'm saying. You are saying that the recovery was to preserve her nerves, not her vision. And her nerves have so deteriorated.
No, her nerves, you see, without nerves, there is no vision. Do you understand?
Doctor,
so if you preserve the nerves,
you will help us to please answer us straight. Was the surgery meant to recover her vision or preserve or what?
The surgery was meant to preserve
her vision or what?
Yes, both her vision and her nerve.
Okay, so it means that even when you declared that she has come to end stage, that surgery was still necessary, even at end stage.
Yes. Yes.
So why is it end stage?
End stage is because the extent of damage is enormous. By the time you get down to 5% of your nerve remaining, that is end stage. We have categories of glaucoma. We have mild, moderate, advanced, and then we have the end stage.
Okay,
end
what
stage
do they call it when the damage has become irrecoverable?
Irrecoverable. You are completely blind. When you've lost all the nerves, you are blind. And there's nothing in the world that will make you see again.
Okay. Thank you. And thank God, say a lot of ophthalmologists are listening to you as you're speaking. Madam, you get any other question before me?
I have a question. When I was referred for Tribec. And yesterday when he was saying, we understand from his speech that he took the decision himself to do tube surgery. Because we heard when he said, when I came back from Kaduna, there was agitation. I was asking him, what did you do in my eye? You told me to go and pay for Tribec. I paid and I have my receipt. And when I reached, I tell other doctors that this is Tribec. They said this cannot be Tribec. Now I want to ask, does any patient in Nigeria have patient rights? And if we have right, I think I know that a patient has the right to be informed. Who signed the authorization letter? You never sit me down one day to counsel me that you are going to change what I was referred to do the tube surgery for me. You didn't do that. I didn't sign any authorization letter because before any surgery is carried out, you have to give the patient counseling. After counseling, you give him authorization letter to sign. From your statement, everybody will know that I didn't know what you did in my eye until I came to Kaduna and you said it yesterday. I was agitating and asking you, what did you do? I told them you said you did Tribec. He said, no, it's not Tribec. So
hold on, madam. Let's get something right. You paid for Tribec.
I paid for Tribec. Yesterday, he told us that...
Wait, now that doctor is looking at your folder, it's easier for him to answer. You can't just be putting it to him the way he tried to put it to me by force. Doctor.
Yes, sir.
Did she pay for Tribec?
No, she didn't.
She has a receipt that shows that she paid for that.
No, she didn't pay for Tribec.
What could have happened to the receipt? Did she forge it?
No, I don't know, but it's okay.
Are you looking at her folder as you're speaking, sir?
Yes. She was referred, even in the operation notes, it was clearly stated there, tube surgery. She was referred to me, like I said earlier, she was referred to me from a professor of ophthalmology. We had already discussed her case. Do you understand?
Madam, can the person with you quickly find the receipt of that payment?
And the referral letter.
And the referral letter.
Even the referral letter did not state whether it's Tribec or tube surgery.
No, I have a referral letter with me now with reference number 0030756. Is that the one you have? 28th of May 2021. BHISID number 00280022. Enrollee's name, Charles Joy. Enrollee's folder number 002591.
Okay, is that from the NHIS people or?
Bayelsa State Health Insurance Scheme.
Okay, no, that's not the referral letter.
What is it?
The referral letter was the one that she brought to us from
what is
NDUTH.
This? What is this? This one, what is it called?
I don't know. It's something to give you authorization to that this person is an enrollee.
The title is referral form.
I'm telling you now that it's usually what they give them to present to the hospital for the services, showing that the bill should be, domicile with the insurance that is covering her.
Okay.
So when we see that, we know that it is okay. We're not supposed to collect money from her. That goes to whatever bill we're going to do. We should go to the insurance company.
Okay, but it carries some information. Hold on, doctor. Hold on.
Okay.
You don't just dismiss it that way. It's carrying some information that you cannot treat in isolation. If there is a referral form and then it is what you know that a patient is not supposed to pay, it's carrying information about that patient. And then as a doctor, I am not sure that you will just look at the patient name and discountenance every other thing. If they have written that this patient is qualified for appendicitis and is asking for heart surgery, you will just do heart surgery. You won't look at what that form is saying. The form is talking about trabeculotomy. That's what is written on the form. We also have another medical report here. If you are not a doctor, you are not God. You are not above mistake. If you make mistake, you say, look, I got it wrong. There are expectations that we have. As a patient, you can't carry out a surgery on her without telling her. She needs to be properly informed. Even when what she is carrying on her form is different from what you have done to her. You still haven't acknowledged it to say, hey.
Consultant Ike, You're
Yes.
taking sides. You're taking sides.
I'm taking side with documents in front of me that I'm telling you now.
Sides.
Please, can you people snap this document and put it on air? I'm taking side with documents in front of me that you even have acknowledged the document. The only thing you are refusing is what is written inside it.
No, I'm not refusing that.
So why are you now? Why are you playing the emotional card that I'm taking side?
You are taking side in the sense that I've explained to you what that is for. I've explained to you.
But the same document you have explained to me has the woman's name, has the woman's number. You acknowledge the woman's name and the number, told me that it is for this. But you are not acknowledging the purpose. Will that document be relevant without purpose?
Okay, thank you. Who sent it?
It's Professor Zunobi that gave me the thing. Before he sent me, he even told me that he's sending me to one Dr. Oko in FMC to go and do Tribec. And the name is on this referral form. He signed
Very good. Very good. Consultant Ike.
I'm with you.
She has Professor Zunobi's number. Can you put him on the call?
I won't put him on call when I have a document in front of me that is signed by him. You can ask me to. I will not put him on call when I have a document in front of him and you acknowledge you know such document. And I've asked for this document to be put online so that you can see.
Is it not good? You said it was signed by Professor Zunobi. I said, okay.
Oga, the document I am saying now is being put online. It's being put online, so it doesn't take anything. You munch it and send to him and ask him, did you sign no about this or not? The institution that has the document, that the document is on the letterhead, is there.
Okay, fine. Fine. Did I tell you about the reason why we did tube surgery?
You never even told me that you are doing tube surgery for me. I never knew until I came back from Kaduna. I started asking you, what have you done in my eye? That me as a health worker, are making me a fool. I tell them it's Tribec. They said, this cannot be Tribec. I said, what did you do? It was then now you said, you consider the end stage glaucoma I'm having. And you took decision that Tribec will be better because it's less invasive, or I don't know. That is what you said yesterday. It's on record. They can still play it back. You said that is what you consider. And you let me remind you what you said that yesterday. You said that yesterday that even the tubes you use in doing this thing is given to you from your American friends. That you know how much the tube is, but you didn't allow me to pay for it. But I'm putting it to you that don't I supposed to sign authorization letter for you to do any surgery for me? Did I sign anyone? Can you answer that one? Another one. Did you do counseling? Did you counsel me as a health worker or as a doctor? Say, this procedure, this is how it will look like. This is the when we go. When we do it, this is the advantage and this is the outcome. Did you counsel me? Any counseling?
Madam.
She's listening to you.
I cannot remember most of our discourse, but I know that there is no how I would have taken you to theater forcefully. There is no way I would have dragged you into theater and then put you on the bed. I didn't sedate you. I did not put you to sleep. There's no way I would have forced you into the theater and then you would be dragging behind that you don't want to go to theater. And I said, no, you must go to theater. Be it as it may. I had said that most of my colleagues, if not all, would not want to undertake surgery on an eye with end stage.
So, but why will you undertake surgery with an end stage? Why will you undertake that? And your explanation now to the patient, does it in any way, your explanation now to this patient.
I've not finished talking now. Let me tell you. Now, we did say that her pressures had consistently remained high. It had, within a year, see the drastic reduction of her nerves. Are you going to just say, sorry, go and count the number of days you have left to see? I said, trabeculectomy is more invasive and has the chances of what we call wipeout syndrome.
I hope you actually know that your colleagues are listening to you. Trabeculotomy is not more invasive because it creates a natural drainage channel. It is not more invasive. It's less invasive.
Who said that?
You're asking me. You may have to consult your book again. You may have to consult your book again.
Oh,
I said to you, it is less invasive procedure because it creates a natural drainage channel, unlike the tube surgery, which involves placing a foreign object on the body. Even medically, medication requirement, trabeculotomy requires less medication.
See.
You are just talking to me because I told you I'm not an ophthalmologist. That's why you think you can just turn me around.
But what would I get to turn you around?
No, but look at what you're saying now.
If I hear this, what you just said now, if I hear it from my colleague, fine, I will accept.
Okay. So if you hear from your colleague that trabeculotomy is less invasive because it only creates it just open up.
No, I said I do the two. So I'm saying if my colleague affirms what you just said, I will rest my case.
Oh, okay. Now, are you aware of the patient's bill of rights? Because part of her complaint now is that you never carried her along in this, even though she requested a different surgery, documented, not verbally. And the document we have shown now and paid for, and you did a different surgery. And she is also saying you never carried her along. Are you saying you have no idea about patient's bill of rights?
The goal is what is, you see, they said the purpose of a thing, if it is not known, abuse is inevitable.
Okay.
What is our goal? Our goal is to reduce the pressure in her eye. So
whose eye? Whose eye do you want to reduce the pressure? Is it her eye or your eye?
Her eye, of course.
Whose decision will it be for the procedure you will take?
Excuse me, what does she want?
Is it now or then you're asking?
Then now, what does she want? Is it not the pressure in her eyes to go down?
And then you could do anything without her knowledge or authorization?
There is no way I could have done that.
But she's saying that's what you did.
Take it from me.
And she's presenting documents to show that it's a different thing she paid for. And you did a different thing.
And it's denying that it's not what I paid for. And what he spoke yesterday, you told us yesterday that if you allow me pay for what you want to do, that I would have not even afford to pay for it. That was what you told us yesterday. That the tube you put in my... You told us yesterday, it's documented in this radio, that if you allow me pay for what you want to do, that I cannot afford to pay for it. That the tube you put in my eye is given to you by your friends from America. That is it. It's an expensive tube and you put it in my eye. Then I put it back to you again. Say, will you have done something to me without seeking my consent? Because counseling was not done. Where is the place of health education? For you to tell your client, this is when I do this thing, this is how it will come. This is the consequence of it. So now, answer.
Sorry, it looks like we are going to end it because there are so many things. Even day before yesterday, when I asked you when you graduated, when you started work, you told me 2005. But my investigation shows that it was 2005 you joined Uniport and you left 2011.
2005, I joined Uniport.
Yes. And you left 2011.
Joined them as what?
Student now.
Jesus. I graduated, I did my medical training in the University of Port Harcourt from 1995 to 2002. Mm.
No, you're here now. That's why I'm telling you, so that you can correct it.
You cannot tell me my educational background. You should ask me and I'll tell you.
Okay. And then are you still retaining what you said about you being specialist on every form of eye surgery, including pediatric, plastic, and all of that?
Like I told you that we take up areas. Okay, let me just give you.
You're not answering straight. You're not answering straight.
Let me give you a background.
This question doesn't require example.
No, I do the ones that I've received skills to do. That's the ones I do.
And which one is that?
I don't do every.
But you told us in the you told us first day that you do everything.
No, as an ophthalmologist,
you said comprehensive. You told the language you used was comprehensive.
Comprehensive, yes. As an ophthalmologist, you are trained in virtually everything.
Doctor, thank you. Thank you for your time. I have asked you a question about Patient's Bill of Rights, whether you know anything about it and what it says. You haven't answered.
I think I'm not very sure. I'm not very sure about it.
Okay. I will want you to research it. So it's been a very good time, and we have heard from you. For what we have seen, we are not comfortable with some of the answers you are giving on this matter. There are areas where this matter was not handled the way it should handle, and we anticipated that it wouldn't have taken anything to say, oh no, I got it wrong here. You're a human being. There is no mortal that can make mistake. And hence it's difficult for you. We will end it here and explore other options to get justice for her.
Okay.
Thank you.
I
Okay.
don't know why it seems so difficult for him to just accept to say there was negligence or there was a mistake at some point, because it's still the same you that is saying she came with a case that is end-stage glaucoma that is irreparable. Maybe he has issues with choice of words. You said it's irreparable. You said it's 5% or 5 something pressure, and there's no way to remedy it. It's still the same you that went forward to operate on her. Because I know that some sicknesses or some ailments that people go into the hospital with, the doctor will advise you and say, this cannot be operated on. Let's leave it. Just let it take its natural course. Yes. If that was what he had told this woman would have forced him.
Hold on, Barrister Pamela. Thank you for that. Hello, good morning, ma'am.
Good morning, sir.
Yes, I believe I'm speaking to Madam Bridget for FCCPC, Federal. Yes. Am I correct?
Yes, you're on to Bridget, FCCPC.
Where be Federal?
Competition and Consumer Protection Commission.
Okay. I am consultant. I can meet you there on live radio, Break the Family and Television, Human Rights Radio and TV, Abuja. It get matter where we have been doing since the past last week, and consumer will go take health service from a particular doctor in Port Harcourt through Federal Medical Center. And the way the matter is going indicates that there are issues relating to Consumer Bill of Rights and then so many other things. The consumer is saying she paid for a totally different procedure, and then a different procedure
was given to her
without even informing her or educating her. Until complications came, she went to other places and it was discovered. Is there anything FCCPC can do? Before I even let you know this, we have called the Medical and Dental Council. The response we got from them was quite disappointing. I don't know the kind of leadership they have. Somebody took the call who is supposed to be a deputy registrar. He started playing politics and said he's one of the deputy registrars. And then he refused even to take a position as a people that are supposed to safeguard the health of the nation. Casually, he dismissed the matter and said, anyway, they can bring complaint. when they bring complaint, they will hear. And we were thinking that they would have known how delicate all of these kind of things are to the health of the nation and be proactive about it. But the response we got from them, it was very, very disappointing. It wasn't something we expected from a head medical and dental council. So, and that is the reason why we are reaching out to Federal Competition and Consumer Protection Council. Commission.
Okay. Okay, Consultant Ike, what I can just ask you to do right away is to send the complainant to us.
Una see so how, una see proactive people, how then they respond. Una see them. This is the simplest thing that that man would have said that day. But he was just full of himself. Una see how institutions that work well. Thank you very much. Which time you want make she come?
Okay, the complainant can come right away. We're in the office, and our office is located at number 23 Jimmy Carter Street, Asokoro. Number 23 Jimmy Carter Street, Asokoro. When she comes, you can just ask of Mrs. Etim or Mrs. Olubumioti. We're in the office.
Na FCCPs, na institution where government is supposed to. In fact, they're supposed to add to una funding because una know what una they do. And when they add value, I think government need to do something about this health. Is it a medical and dental council?
Very correct.
Something need to be done about them because even this, if they are doing what they should do, we not go hear this kind of story.
Sure.
The only reason why this person come be say the people, even patients, have lost confidence in them.
Yeah, they have lost hope.